Okay, chronic regional pain syndrome, and we're just going to go with that. Lyme, Chiari, but it does describe. It's more of a descriptive term. And is it Lyme that's wreaking havoc in your system? Well, since that's difficult to image, I can only talk about what we could image today. What do I think is going on? When people are this weak, I always suspect a CSF leak. So I think you're leaking CSF. I was leaking CSF, so maybe I see it in other people when they look like me. Okay, so that's full disclosure. So here, what do we see? What did the imaging show us? Some interesting things. So you have the Chiari malformation. They did the Chiari surgery. What can make a Chiari worse? A CSF leak, a tethered cord, jugular vein compression, an atlas subluxation, hypermobility. These are things that, so you had the Chiari surgery. We're still symptomatic. We have a lot of venous congestion in there, which again would foster some of the other things that we expect. And we've got some great imaging to document this stuff. So what kind of set you up? You were 12 years old when you started having all this pressure in the head and some really funny symptoms. Was it the Chiari that was doing this? I don't know, but you've had it so long that we're able to see manifestations of some traction of structures that have been inured over time. So just the highlights. Yes, we have a calcification of a styloid. And how old are you?
26.
26. So we're already seeing calcification of a styloid. I thought you might have had Schulman's, which is a kyphosis, but you don't have that. So we've got congestion of the venous system. We've got entrapment there. We've got entrapment on both sides. And we have this hyoid that is misshapen. And we 3D printed it so you can see it, how misshapen it really is. And we'll show that to you in a minute. But it's basically been traction and under a load, so it's longer on this side, shorter on that side, misshapen. So we have a kyphosis of the cervical spine on a young girl, cervical curve restoration. You're resistant to it. Some of the things that would normally work don't seem to be working. And here's what we found. So back in here, we have these massive calcifications that I have not seen on anybody. And I went back and looked at a bunch of different scans to see if I could see it. It's not aponeurosis. Here, actually, we'll pull this dissection over here. So there's a good shot of it. And so that tells me that the strap muscles in the front are under a contraction or a load. So the sternohyoid muscle comes around from the back of the sternum and has to come past that a little bit. Now, this is normal anatomy, which nobody has. Everybody's plumbed and wired and has different attachments. So the closest attachment point is going to be the sternohyoid muscle. So my current working diagnosis is that those calcifications are from the origin of the sternohyoid muscle, which goes to the hyoid. We knew going into this scan that there was a contracture, or there's something going on in the anterior compartment that was keeping you in a kyphosis. I would think a torticollis from birth or something like that, but it never met that threshold. We don't really know. It's idiopathic. We're not really sure what caused it, but we do know that there's a traction that's going on, attachment of the hyoid right here, shortened, hyoid being distorted, and actually those are the first rib muscles. That's a different thing. Here's another view. Look at those calcifications. Those are not growth centers of the manubrium. I checked that out. There's a good view. It's that traction of the anterior strap muscles there. That was fine there. You got a little misshape in the back there that may be playing out with left and right head rotation and trapping some things in there. So you do move when there's shortening or muscle contracture, there's going to be immobilization or relatively lack of motion in certain parts of the spine. And I think your hypermobility at the cervical cranial junction is secondary, might be secondary to the neck kind of stuck in a kyphosis, so that the upper neck is the only part that's really moving. Again, there's another shot of the calcifications there in a funny place. So there we have the styloids that we've come to see on other people when they're under a load like that, the jugular vein compression. So here, these are the loads that we see, the forces coming through here. We're seeing that the hyoid is being pulled and tractioned this way. The hyoid is being pulled down by the strap muscles here. You've got your first ribs that are coming down a little bit, and we see that pulling the scalenes anterior. Looks like the hyoid is actually kind of pulled in a nerd in a different direction. Does the camera do this hyoid justice? I mean, there you can kind of see how it's misshapen. I'll put it down there. Yeah. So that tells you the forces that have gone through it. Sometimes people have to suffer long enough before we can see it clearly. That's just what happens sometimes. Okay. Yeah, so I also think that the transverse processes of the atlases get a little bulbous and get a little large when they're under a load, just like we saw behind the manubrium there. Again, good view. Yeah, look how funny that hyoid is. Right, and some muscle. So I'm not saying you're tongue-tied, but it's better for you to not talk. We know this. I think it has to be. So one of the thoughts was, oh, is there a contracture of this muscle? But I guess I'm thinking that these muscles for speech and the tongue movement are probably normal, and that they're just being pulled on and tugged, and that's what you feel, all those symptoms up in there. Another view of the hypoglossus muscle. So here we are again. Well, the interesting thing about this is that your atlas misaligns in one way when you're lying down and another way when you're upright. So we've documented that it's moving a little too much. And that was before. Were you moving too much before you had the Chiari surgery? I don't know, but we know that Chiari surgeries or styloidectomies, they foster more mobility. And you being such a young girl, we're not in a big hurry to take these styloids out and foster more hypermobility. We need this tightened up. That's probably the next order of business. I know these jugular vein compressions are giving you symptoms. I think you're leaking CSF. That's causing symptoms. But we can't go from the frying pan into the fire here. We're seeing some motion in there. All right, so this was let's see here. There's lying down. So that's what you look like when you're upright. The atlas goes up to the left, it goes anterior on the left, and when you lie down, it goes anterior on the right and even drifts up to the right. So are your symptoms coming from exaggerated motion to the left or exaggerated motion to the right? Well, that's up for, well, I don't know. I don't know yet. Okay, so here we are. Lying down, you can see how far the atlas drifts forward on the right and even up to the right. And here it is weight bearing, showing how it goes to the left. Right, so here we are lying down, lack of a curve. And actually this is about as good as your curve gets lying down. You can even sense that there's some sort of contractures in the front there. And that's when you go weight bearing. So going weight bearing, we know there's a looseness in here. We would like the ligaments back here to be tighter, the rubber bands back here to be tighter. But my sense is that if we tighten those up, these contractures in the front, we're not going to get very far. So we need to lengthen what's in the front, tighten what's in the back at the same time. So this position that you're in, one of the things we look for is potential locations for CSF leak. So we're seeing some of the enthesopathies. Basically, it's under a load. And here we found a big one that's sticking out and indenting the dura. There's another view of it. So I'm always looking for potential spots for a CSF leak. There's another view of it, how it sticks out. And that's from having that kyphosis in the thoracic spine as a young girl. And we'll actually drill down on that in just a moment. But these are ectopic arachnoid granulations. We did end up taking a full inventory of the venous drainage system. So that's the interface where the CSF drains into the venous system. And then when they are a little out of position, they can cause decreased blood flow going out of there. And you've got 3 of those on the right, 1 of those on the left. Some people put stents in there, and this is not giving me what I wanted. Oh, let's see if I can get back. All right, so right head rotation, we showed how much it moves, and actually we 3D printed that too. Can you come down here a second? All right, so this is a model of her dura, and this is where that it pops in there quite tightly. That's where the spur is, and this is an indentation on the dura. Now, can I say it's leaking there? You can't say for sure, but you can see and put your finger on it where it's indenting in there, and that would be a likely place for a CSF leak. So we got great models of that. We got great models of how far she moves with left and right head rotation. The styloids being funny shaped, you can see that it seems like the transverse process of atlas is pushing the jugular and displacing the styloid over there. And she does move too much. Let's see here. Yeah, this one you can see that the odontoid process is pretty much touching the skull almost. So her symptoms are coming from hypermobility, venous congestion, CSF leak probably, Lyme is not helping. Any questions, anything you want me to talk about that I might have missed? Yeah. Okay.
What about the vein from in the back of the neck?
Oh, that was the adaptive. So there's a lot of adaptations here. So some people think that you can tie off a jugular vein. It's fine. It doesn't matter during surgery because the body will adapt and you don't have to worry about it. Well, not everybody can adapt. The good news is that you do have some collaterals that are helping you to adapt. And this is a big, giant emissary vein. Started off, you can see the venous congestion through there, and it's trying to help accommodate for those entrapped jugulars. And you can see the venous congestion down and through there. We've had them to where they get a stent in there, although you can't get a stent in these, they're too much pressure, or a styloid removed, and this will collapse. So I had a neurointerventional radiologist that he observed all this on somebody else. As soon as he put the stent in there, all this collapsed. And of course, the CSF drains in through there by a pressure gradient, so we don't like this backup of pressure. And yeah. Okay, thank you very much.